Hi there, John Cummins. Thought I'd talk to you about coronary calcification. We did a segment a couple of sessions ago on, how do we know if we've got arterial disease? So it's a bit odd, isn't it, having calcium in arteries? I thought calcium was in bone, and it's true, it is a bit odd. But the evolution of events is that in our Western culture, as little children, probably in the second decade of life, say from 10 to 20. We often, with our eating patterns and things, develop little fatty streaks, they're called, in the arteries. Ultimately, it ends up being cholesterol inside the wall of the arteries. Now, how does it get there? Well, first of all, every artery has a sheet of cells, and the cells have little gaps between them. It's called the endothelium. If the gaps get damaged, then cholesterol can get in there. And the gaps can get damaged due to bad diet, high blood pressure, smoking, diabetes, a very high cholesterol alone, getting older, being a male, all those risk factors are thought to damage that endothelium. A little bit of cholesterol starts sneaking in there. But then in your 20s and 30s starts, getting to be a bigger and bigger bubble of cholesterol. It will start to attract inflammatory cells, white blood cells. These then become metabolically very active, so it's like this little smouldering fire now. They secrete proteins that then cause more inflammation. And so these hotbeds of inflammation in the arteries, if that was an artery, it can either, and the blood was going one direction, it can either bend inwards and narrow the artery, and that will often cause angina and draw you to medical attention. It can bubble outwards, in which case it doesn't really matter. But the worst thing is it can actually rupture, pop open, and then the body says, aha, look, there's a cut there inside this arterial wall, because it's looking directly at the cholesterol, not the endothelium anymore, because it's been ruptured, and says, I'm going to heal that, and it'll dump a lot of platelets and a clot on there. And it's actually the body's response to the broken plaque that causes the heart attack in terms of thrombus, and which is why we put people on aspirin after a heart attack or an event, because aspirin stops the thrombus, it stops the platelets from coagulating. Now, if nothing happens, and the plaque gets very mature and old and it never ruptures, luckily, it'll calcify. And we think the calcium is there in response to injuries. But what's beautiful about the calcium is that you can quantitate it with CT imaging, and you can reference it, and I can tell you exactly how old your arteries are compared to someone 10 years older, 10 years younger. I might be 50 or 60, but I may have the arteries of a 70 or 80-year-old because the calcification quantification has been studied, researched for 30, 40 years, and we know exactly how much calcium you should have at certain given ages. So, for example, in your 40s, you've probably got a 60% chance of having no calcium. In your 50s, it might be a 50% chance. In your 60s, it's probably a 30% chance of having no calcium. But it really helps us define risk and give someone the biological age of their arteries. So that's the evolution from fatty streak to soft plaque build up, to rupture, or more mature plaque that's deeper that doesn't rupture, to then calcification. So the calcification is really a marker of how much plaque you've built up in your life, if any, up until the age that you are. And it gives you a trailing effect of how much plaque there's been there. And the point also is the calcium never hurts anyone. It's not, the calcium is like a rock. But where there's calcium, you can bet your bottom dollar there's going to be soft plaque evolving elsewhere in the arterial tree that needs your attention, needs some treatment. So hopefully that's helpful, and look forward to seeing you again soon.